Welcome. This presentation is a practical walkthrough of how to design, conduct, and publish a systematic review and meta-analysis built specifically for clinicians who are not statisticians. It's based on the 24-step guide published by Muka and colleagues in the European Journal of Epidemiology in 2019, which distills a complex process into an ordered checklist. My aim across these slides is simple. By the end, you should understand what each step is, why it matters, and what you personally need to do without needing a statistics degree. Think of a systematic review as a research project where your subjects are studies rather than patients. We move from a focused question through a transparent search and screening process to either a narrative summary or a pooled quantitative analysis. Let's begin.
Let's ground ourselves in two definitions because people often blur them. A systematic review is a whole method. You take one focused clinical question and you try to find every relevant study, appraise the quality of each, and summarize them in a way another team could reproduce exactly. That reproducibility is what separates a systematic review from an ordinary narrative review. A meta-analysis is narrower. It's the statistical step where you pool the numbers from those studies into one combined estimate. And crucially, it's optional. You only pool when the studies are similar enough that combining them is meaningful. We'll come back to that decision at stage 20. The mindset I want you to carry through the whole talk is on the left. Treat studies as your patients. The same discipline you use clinically, a precise question, a defined population, methods you'd be comfortable defending, is exactly what makes a review trustworthy. On the right is the evidence pyramid. Well-conducted systematic reviews and meta-analyses sit right at the top, above individual randomized trials, because they synthesize across the whole evidence base, rather than resting on a single study.
24 steps sounds daunting, so here's the map. Everything falls into 4 phases. Phase 1 is planning, steps 1 to 6. You frame the question, assemble the right team, and write and register a protocol before you touch a single database. Phase 2, steps 17 to 16, is the mechanical engine of the review, searching multiple databases, stripping out duplicates, screening titles and abstracts in pairs, retrieving full texts, and extracting data onto a standard form. Phase 3, steps 17 to 23, is where judgment comes in. You appraise the quality and risk of bias of each study, decide whether pooling is even appropriate, and if it is, run the meta-analysis and explore heterogeneity. Phase 4 is the finish line, step 24. Update your search if it's gone stale, report against the PRISMA checklist, and submit. The key discipline is that you move through these in order. Each step feeds the next, and skipping ahead is how reviews lose their rigor. For the rest of the talk, we'll take the phases one at a time.
Phase 1. Planning. Before we search a single database, we frame the question, build the team, and register a protocol. Everything that makes a review trustworthy is decided here, up front. Let's take these first 6 steps one at a time.
Step 1 is the foundation, and it's where clinicians have a real advantage over pure methodologists. You already think in terms of patients, interventions, and outcomes. Write down your primary aim and any secondary aims in plain clinical language first. Then formalize it using the PICO framework: population, intervention, comparator, outcome, and optionally S for study design. On the right, I've built out our running example, which will carry through the entire talk. In preterm infants under 34 weeks, does probiotic supplementation compared with placebo reduce necrotizing enterocolitis, looking specifically at randomized controlled trials? Notice how each letter maps to a concrete decision you'll make later. Don't be discouraged if a systematic review already exists on your topic. That's fine, as long as yours adds value, for example by including newer trials or a quantitative synthesis the old one lacked. The tip is the acid test. Your question should be specific enough that 2 colleagues screening the same paper would reach the same include-exclude decision. If they disagree, the question is still too loose.
You cannot do a rigorous systematic review alone, and step 2 is about building the right team before the work starts. The single most valuable member for a clinician to recruit is a medical librarian or information specialist. The evidence shows that having a librarian as a co-author measurably improves the quality of the search, and search quality determines whether you find all the relevant studies or miss them. Balance matters too. You want clinical content experts who know the topic, a methodologist or statistician for the analysis, and at least 2 reviewers who can screen independently, plus a senior person to break ties. Interestingly, the guide warns against teams that are too dominated by clinical experts. They tend to hold preconceived opinions about what the answer should be, spend less time on the mechanics, and produce lower quality reviews. So as the clinician driving this, your job is partly to invite in the methodological rigor you don't personally specialize in. Finally, name a leader. Not necessarily the most senior person, just whoever will keep the protocol followed and the team coordinated.
Steps 3, 4, and 5 are done in parallel, and together they lock in the reproducibility that defines a systematic review. Step 3 is the search strategy. You write specific search strings for each database, broad enough to capture every relevant study, but targeted enough that you're not drowning in thousands of irrelevant hits. This is exactly where your librarian earns their place. Step 4 is your inclusion and exclusion criteria, shown on the right for our probiotics example. We include randomized trials in preterm infants, comparing probiotic against placebo where NEC is reported. We exclude animal studies, anything without a comparator, and reviews or editorials. The critical principle is that you set these rules before you see the search results. That's what stops you from unconsciously including or excluding studies to get the answer you were hoping for. Step 5 is the data extraction form, a standardized template capturing study details, population, intervention, outcomes, and effect estimates. And please pilot it on about 5 studies first. You will always discover a field you forgot, and fixing that now is trivial compared with re-extracting 40 papers later.
Step 6 is writing the protocol and registering it, and this is the step clinicians most often want to skip. Please don't. The protocol pulls together everything from the planning phase into one document: your research question and aims, your inclusion and exclusion criteria, the full search strategy, and your pre-specified analysis plan. Get experts to review it before you start screening. Then register it publicly, most commonly on PROSPERO for health and social care reviews or with Cochrane for intervention reviews. Registration is genuinely your best defense against accusations of bias. By timestamping your plan before you've seen the data, you demonstrate that you didn't quietly switch your primary outcome or change your methods once the results started coming in, a problem known as outcome switching that badly undermines trust. It also prevents wasteful duplication, so 2 teams don't unknowingly run the same review. Practically, PROSPERO is free, takes about an afternoon, and an increasing number of journals now ask for your registration number at submission, so this small investment pays off directly. Phase 2. Search and screen. This is the mechanical engine of the review, the most time-consuming part, but also the most systematic. We search widely, remove duplicates, screen every record with 2 independent reviewers, and extract the data. Discipline here is what makes the analysis that follows trustworthy.
Now we're into the engine room, phase 2. Steps 7, 8, and 9 are the mechanical start of gathering your evidence. Step 7. Run the search you designed in at least 4 databases. The guide specifically recommends Embase, Medline, Web of Science, and Google Scholar as a minimum because no single database indexes all of medicine, and each one uses its own search syntax. If your question touches psychiatry, psychology, or nursing, add PsycInfo and CNow. Step 8, collect every result into a single reference manager. EndNote, Covidence, or Rayyan all work. Step 9, eliminate duplicates, because the same study will show up across multiple databases, and you don't want to screen it 3 times. Deduplication is tedious but essential, and the tools have features to speed it up. My practical tip: use a purpose-built tool like Rayyan or Covidence, rather than trying to manage this in Excel. The guide explicitly advises against Excel for screening. It's slow, it's error-prone, and these dedicated tools will save you hours and reduce mistakes.
Steps 10 through 12 are the screening file, and the golden rule here is independence. Step 10. At least 2 reviewers screen every title and abstract separately, without seeing each other's decisions. This isn't bureaucratic box ticking. A single reviewer inevitably misses relevant papers and brings their own unconscious bias, and a second independent reader catches both. Step 11. You compare the 2 reviewer selections. Where they agree, the decision stands. Where they disagree, they meet to reach consensus. And if they still can't agree, a senior 3rd reviewer breaks the tie. That's the Venn diagram on the right. Step 12, for the papers that survive title and abstract screening, you retrieve the full text and apply your selection criteria again, because abstracts often hide whether a study truly meets your inclusion rules. One reassuring practical point: you don't need a single person to read all 1,000 records. As long as every record is seen independently by 2 reviewers, you can divide the workload across the team. That makes this far more feasible than clinicians often fear.
Steps 13 to 15 make sure you haven't missed anything, and then formalize what you found. Step 13. Contact experts and study authors directly. They may know of ongoing or unpublished studies, or be able to give you data that was reported for one outcome but not another. This matters because relying only on what's easy to find biases your review toward published positive results. Step 14 is citation chasing in 2 directions, by reading the reference lists of your included studies and by finding newer papers that cite them. Scopus and Web of Science make this straightforward. Any new studies loop back through your screening process. Step 15. Finalize your list of included studies and draw the PRISMA flowchart, shown on the right with the numbers from our example. From around 1,248 records identified, down through deduplication and screening to 14 studies included. That flowchart is not decoration. Reviewers and readers use it to verify your process was complete and transparent, so every number has to reconcile. The records you excluded plus the ones you kept must add up at each stage.
Step 16 is data extraction, and it closes phase 2. Using the standardized form you piloted back at step 5, 2 reviewers independently extract the relevant data from each included study: the study characteristics, the population, the intervention details, the outcomes, and the effect estimates. The right-hand card shows what a single row looks like for one of our trials: study and year, sample size, which probiotic, the NEC event counts in each arm, and the resulting risk ratio. 2 things make or break this step. First, independence again. 2 people extracting separately catches transcription errors, a misplaced decimal, the wrong column, that would otherwise flow straight into your pooled result and quietly distort it. Second, consistency. Convert everything to the same units and the same effect measure before you record it. Mixing millimoles and milligrams per deciliter, or mixing risk ratios with odds ratios, is one of the most common silent errors in meta-analysis. The principle is simple, but unforgiving. Garbage in, garbage out. Clean, consistent, double-checked extraction is what makes the analysis in the next phase trustworthy.
Phase 3. Appraise and analyze. Now, clinical judgment returns. We assess the quality and risk of bias of each study, make the crucial decision about whether pooling is even appropriate, run the meta-analysis if it is, and finish by rating our overall confidence in the evidence.
Phase 3 is where clinical judgment re-enters, and it opens with step 17, assessing the quality and risk of bias of each included study. 2 reviewers do this independently, just like screening. The key insight is that a pooled result is only as good as the studies inside it. A rigorously conducted trial and a badly biased one should not carry equal influence over how you interpret the evidence. You match the appraisal tool to the study design, shown on the right. ROB2 for randomized trials, the Newcastle-Ottawa scale for observational and cohort studies, Robbins I for non-randomized interventions, and Quadas 2 for diagnostic accuracy studies. Each looks at domains like how randomization was done, whether outcomes were measured objectively, and how much data went missing. One nuance clinicians should hold on to: a study at high risk of bias isn't automatically thrown out. Instead, its rating shapes how much weight you give its findings and how confident you are overall. You flag it, you discuss it, and later, at the grade step, high risk of bias becomes a reason to downgrade your confidence in the whole body of evidence. Transparency here is everything. Report each study's rating, don't just reduce it to a single number.
Step 18 is preparing your database. You collate all the extracted numbers into an analysis program. That could be R, which is free and increasingly the standard, or Stata, or RevMan, Cochrane's own free tool that's very friendly for beginners, or even a well-structured spreadsheet for simpler work. Step 19 is the descriptive or narrative synthesis. This is where you summarize in words and in a table what your included studies actually were: the populations, the interventions, the outcomes, the direction and consistency of effects. I want to stress something here that clinicians often misunderstand. Every systematic review has a descriptive synthesis, but not every review has a meta-analysis. Describing your evidence clearly is valuable in its own right. And if you reach the next step and find your studies are simply too different to pool sensibly, a well-written narrative synthesis is a completely legitimate and publishable endpoint. It is not a failure or a lesser result. Sometimes honestly saying the evidence can't be combined is the most useful conclusion you can offer.
Step 20 is the single most important decision in the whole quantitative side, and it's a yes or no gate. Should you actually pool these studies into a meta-analysis? The danger is combining apples and oranges. If you average studies that are fundamentally different, you get a precise-looking number that means nothing. So you assess two things. First, clinical and methodological similarity. Are the populations, interventions, and outcomes close enough that one combined answer is meaningful? Second, statistical heterogeneity, which you quantify with the I-squared statistic shown on the right. I-squared tells you what percentage of the variation across studies is real rather than due to chance. Roughly under 25% is low, 25 to 50 moderate, 50 to 75 substantial, and above 75 is high. High heterogeneity is a signal to investigate why the studies disagree, or to reconsider pooling at all. If you do pool, you choose a model. A fixed effect model assumes every study is estimating one identical true effect. A random effects model allows the true effect to vary across studies. For most real clinical reviews, there genuinely are differences between studies, so random effects is usually the safer, more honest default. When in doubt, that's the one to reach for.
Step 21 is exploring heterogeneity, and this is often where the most clinically interesting findings hide. When your studies disagree, the useful question isn't just how much, but why. You investigate with subgroup analyses. You split the studies by characteristics like study design, drug dose, or patient population, and see whether the effect differs between groups. For our example, probiotics might reduce NEC strongly with one bacterial strain, but not another, or in extremely preterm infants, but not late preterm ones. That's far more useful clinically than a single blended average that hides the real pattern. When you have around 10 or more studies, meta-regression lets you formally test which factors drive the differences. The visual on the right is a forest plot, which you must be able to read. Each horizontal line is one study, the square is its effect estimate, the line is its confidence interval, and the vertical dashed line is no effect. The diamond at the bottom is your pooled result, here a risk ratio of 0.55, sitting clearly on the side favoring probiotics. One firm rule: pre-specify your subgroups in the protocol. Subgroups you invent after seeing the data are hypothesis-generating at best and actively misleading at worst, so decide them in advance.
Step 22 is checking for reporting bias, and the main culprit is publication bias, the well-documented tendency for studies with negative or non-significant results to never get published. This matters enormously, because if the small trials that found probiotics didn't help were quietly filed away and never appeared in any database, then your search only found the positive ones, and your pooled estimate overstates the benefit. The classic detection tool is the funnel plot on the right. You plot each study's effect against its precision, and in the absence of bias, the points form a symmetric inverted funnel. Larger, more precise studies near the top and center, smaller ones scattered wider below. If there's a conspicuous gap on one side, particularly where small negative studies should be, that hints some are missing. You can back up the visual impression with a statistical test like Eggers. One important caution: funnel plots are unreliable when you have fewer than about 10 studies, and asymmetry can also be caused by genuine heterogeneity or simple chance, not only publication bias. So interpret it carefully. Finding suspected bias doesn't prevent you from publishing, it just means you report it honestly and temper your conclusions accordingly.
Step 23 pulls all of your appraisal together into a single, honest verdict using the grade approach. Grade rates the overall certainty of the evidence for each outcome into one of 4 levels: high, moderate, low, or very low, shown on the right. The logic is intuitive for clinicians. Randomized trials start at high certainty because randomization controls confounding. Observational studies start at low. Then you downgrade for problems: serious risk of bias from step 17, inconsistency when studies disagree, in precision when confidence intervals are wide, or in directness when the studies don't quite match your question. Occasionally, you can upgrade observational evidence, for instance, when there's a strong dose-response relationship. Why does this step matter so much? Because grade is the bridge from your analysis back to the bedside. A busy clinician reading your review doesn't want to reverse engineer your risk of bias tables. They want one clear statement. We can be highly confident, or only moderately, that probiotics reduce NEC in preterm infants. That's what grade delivers. And as with every judgment step, two reviewers should agree the rating, with a third to settle disagreements, keeping the same independence principle throughout.
Because the fixed versus random choice trips up so many first-time authors, this slide slows down on it. On the left, the fixed effect model. Its core assumption is that every single study is estimating exactly the same true effect, and any differences between them are purely sampling error, random noise. Under that assumption, larger studies dominate the pooled result, and small ones barely register. You'd only use it when your studies are genuinely near identical. Same population, same protocol, same design. On the right, the random effects model. It assumes the true effect actually varies from study to study, scattered around some average, because real-world studies differ in their populations, doses, and settings. It spreads the weighting more evenly, so smaller studies count for more than they would under fixed effect. The trap at the bottom is the one to remember. A lot of people choose the model based on whether a heterogeneity test came out significant. That's the wrong reason. Heterogeneity can exist even when the test fails to detect it, especially with few studies. For the overwhelming majority of clinical reviews, real diversity between studies is present, so random effects is the more honest default. If you take one thing from this slide, when unsure, choose random effects, and never let a single significance test make the decision for you.
Phase 4. Report and publish. The final stretch. We refresh the search if it's gone stale, report against the PRISMA standard so others can reproduce our work, and submit. A review nobody can follow can't change practice, so reporting well is part of the science, not an afterthought.
Step 24 is the finish line. Update, report, and submit. First, update. Systematic reviews take months, and if it's now been more than 6 to 12 months since you ran your original search, new relevant studies may have appeared, so rerun the search and screen anything new before you submit. Nothing is more deflating than a reviewer pointing to a major trial you missed because it published while you were writing. Second, report to standard. For most reviews, that means PRISMA, the preferred reporting items for systematic reviews and meta-analyses, or MOOS for reviews of observational studies. You attach the completed PRISMA checklist and your flow diagram from step 15. These reporting standards are what make your review reproducible and usable by others, which is the entire point of doing systematic work in the first place. A review nobody can follow or verify can't safely change practice. Third, invite content experts to review your manuscript before submission and acknowledge their help. My practical tip, fill in the PRISMA checklist as you write, not the night before submission. It doubles as your own quality control pass and will catch gaps while you can still fix them easily.
Before we close, here are 7 pitfalls that most commonly sink an otherwise well-intentioned review. Think of this as a pre-flight checklist of what to avoid. 1. A fuzzy question. If your PICO is vague, screening becomes inconsistent and the whole review loses focus. 2. A thin search. Relying on one database or skipping the librarian, which means you miss studies and bias your findings from the very start. 3. Solo screening. One reviewer misses papers and brings unconscious bias. Always screen in pairs. 4. No protocol. An unregistered review invites the suspicion that you switched your outcomes after seeing the data. 5. Pooling apples and oranges. Combining studies that are too dissimilar gives a precise-looking number that's actually meaningless. 6. Post hoc subgroups, invented after seeing the results, which mislead far more than they reveal. Pre-specify them. And 7. Ignoring publication bias, leaving the possibility of missing negative studies unexamined, which overstates the apparent benefit. Every one of these is avoidable if you follow the 24 steps in order and hold to the principles of transparency and independence. None of them require you to be a statistician. They require discipline.
This slide is your take-home reference.
all 24 steps on a single page, grouped by the 4 phases, so you can screenshot it and keep it beside you when you start your own review. Reading across, the plan phase, steps 1 to 6 in teal, question, team, search strategy, selection criteria, data form, and protocol with registration. The search and screen phase, steps 7 to 16, running the search, collecting and deduplicating references, screening in pairs, comparing, full-text screening, contacting experts, citation searching, drawing the PRISMA flow, and extracting data. The appraise and analyze phase, steps 17 to 23 in Rust, risk of bias, preparing the database, describing the studies, the crucial pool or not decision, exploring heterogeneity, checking reporting bias, and rating the evidence with grade. And finally, publish, step 24, update the search and submit. Notice the shape of the workload. The search and screen phase has the most steps and takes the most time, while the intellectual weight sits in planning and appraisal. If you follow this checklist in order, you have a complete, rigorous, publishable systematic review. No statistics degree required, just method and discipline.
Let me leave you with the single idea that ties this whole talk together. What makes a systematic review trustworthy is not statistical wizardry. It's rigor, a focused question, a transparent, comprehensive search, independent screening in pairs, honest appraisal of quality and bias, and clear, standardized reporting. Every one of those is within your reach as a clinician. Where genuine statistical expertise is needed, choosing models, running the pooled analysis, interpreting heterogeneity, that's what your methodologist and statistician are for. And knowing when to lean on them is itself part of doing this well. So don't be intimidated. If you can run a good clinical case, you can lead a systematic review from the first idea all the way to publication. Follow the 24 steps, hold to transparency and independence, and the evidence you produce can sit right at the top of that pyramid and genuinely change practice. Thank you.